Good afternoon, and thank you for joining us in today's final broadcast for ECCMID TV, brought live to you from our studio in Pavilion 1 here at the ECCMID Congress Center in Lisbon, Portugal. I'm very happy that for my final guest of today, I have Dr. Timothy Rawson with me, who is another recipient of the Young Investigator Award for Research in Clinical Microbiology and Infectious Diseases. So a warm welcome to you, Timothy.
Thanks so much.
Glad you could make it here live in our studio.
Thank you.
Just for our viewers, you are a clinical fellow in infectious diseases and medical microbiology in at the Imperial College in London, where you are also an honorary clinical lecturer. And your research focuses on antimicrobial stewardship and precision prescribing of antimicrobials. And today I think yesterday you received, yes, it was yesterday. You had a presentation at the award ceremony on a very interesting topic, I believe. Can artificial intelligence and real-time monitoring support optimized antimicrobial use? Can it?
Yeah, that's a million-dollar question, really, I guess. But yeah, I guess I should say first of all, it was an absolute honor to be given this award, and I felt very privileged to be able to present my work yesterday. And I guess that the question and the theme of the research really is whether technology can help us in terms of optimizing antimicrobial use. So we know that optimizing antimicrobials often focus on sort of maximizing clinical effectiveness whilst minimizing all those harmful consequences of using antibiotics. But when we try and assess that in real life and in clinical practice, often a lot of the factors that drive variability between individuals are either difficult to quantify or measure at all. Mm-hmm. So a lot of the work that we undertake at Imperial focuses on whether you can develop technologies to help bridge some of those gaps and sort of approach more truly individualized antibiotic therapy.
And what kind of characteristics should the AI help on? Is it clinical characteristics?
Yeah. Or? So AI is a fantastic tool, and it's something that I think we're seeing at the conference here. There's so many more sessions on the artificial intelligence approaches, whether focused on the microbiology lab or on the sort of clinical interface around prescribing. And so you can really use it as a powerful tool to help essentially perform statistics on large amounts of data, which is available to us now from electronic health record systems, for example. And so there are lots of different ways you can approach that. One way we try and approach it is by looking at using the optimal variables to help make predictions about things. So rather than just focusing on what we would traditionally think of around optimizing antibiotics, is selecting that antibiotic which targets the organism which we think or we know that we're targeting. Well, actually, we need to be a bit more augmented in the way we approach decision making. So, we need to think about how we support risk prediction using all of these variables that are available to us. We need to think about forecasting, even thinking about how you can apply more individualized technologies to the way you communicate information with patients. I guess another interesting area, which I spoke a little bit about yesterday, was also around optimizing the dosing of antimicrobials. Mm-hmm. And we're beginning to understand more and more now the variability in pharmacokinetics and pharmacodynamics of antibiotics. And this variability is driving differences in outcome. So another area of our research is to focus on the development of biosensor technologies and methods of real-time drug monitoring, which can then also feed back into those algorithms, so providing more rich data to actually support decision-making overall.
So do we still need doctors?
Yes, I always really like the phrase that what the algorithm needs is a good clinician. And actually what these are, that they're for decision support. So it's trying to provide a way of allowing the physician to actually use all of that data in a more optimal way without having to assess all of it themselves. So can we provide them that valid prediction of whether or not there's a high, medium, or low likelihood of infection, for example, and then allow them to use that piece of information, like you would a blood test, for example, to actually make your clinical decision.
Yeah. Yeah, and so the prediction models, they're not only just to predict how the treatment response is going to be, or if you're selecting the right agent for the right pathogen, but you're looking at a broader spectrum.
And it's just trying to integrate different types of decision support together as well. So you might develop algorithms which help with prediction, for example, but then also can you bring in methods of real-time monitoring, and rather than requiring on in vitro diagnostics, can you begin to assess sort of in vivo characteristics of host response or how the organism is responding to treatment, so that you can be more individualized in the way that you then make adjustments to therapy.
So if all these tools prove to be very effective, what is your hope for the outcomes? Do we have shorter hospital admission times? Do we get less antimicrobial resistance?
Well, it's a really interesting question, and what do you set your outcome goal as? But I think one of the great things about this is by providing more granular data, which you can understand and respond to, the hope is that you'll be able to understand better what actually is the appropriate duration of therapy for this individual patient, or how do we optimize the delivery of that drug to shorten the duration requirement. Yeah. So what you can do is move away from sort of that one-size-fits-all approach where we just give everyone 5 to 7 days or pick a number between there, to actually saying, well, in this individual, they've responded well over the first 72 hours and there's a high likelihood we'll be able to stop now. And it allows you to be more individualized and just move away from that reliance on sort of these very blunt decision tools which we use at the moment.
And I take it you believe it's feasible. It's not a utopia.
No, I mean we're starting to see.
We can manage this.
In terms of artificial intelligence. I mean, in 2006, I think it was, there was studies showing that you can develop these causal probabilistic networks and implement them in practice. And so people have been doing it for a long time. But it's actually how you sort of refine them, bring it all together, and then actually how you demonstrate benefit. And one of the big challenges is that often these decision tools are implemented in isolation. And actually, we know from all of our normal stewardship approaches that you need to take multimodal approaches to support adoption and behavior change on the long term. And so it's about trying to bring this package together which fits into the kind of the normal decision pathway, but provides optimal information for decision making.
It's very interesting. Yeah, I also learned that you researched the impact of COVID-19 on bacterial infections and microbial use.
Yes.
Can you just recap that a little, or I don't know if you can do that quickly or
yeah, I can try. I can try and summarize it a little bit. So I guess it was early on in the pandemic. Our research group were interested in optimizing antibiotic therapy and understanding how to improve prescribing.
Yeah.
And so it became quite apparent from clinical practice that there were high rates of antibiotic prescribing going on in our local practice, but actually low rates of observed bacterial infection. And so within our group, we undertook a sort of a range of projects, first of all looking at the description of rates of bacterial infection versus rates of prescribing, and then have looked at some more epidemiological data to understand what's actually the impact of COVID has been on prescribing in different areas. And one piece of work that was led by one of my colleagues, Nina Zhu, that I supported, looked at antibiotic prescribing in primary care during our region during the initial first 2 waves of the pandemic. And we observed some really interesting findings because a lot of the data is focused on the high rates of prescribing in hospitals, particularly in critical care and sort of higher rates of healthcare-associated infections. But during the pandemic in primary care, we actually observed a reduction in the consumption of antimicrobials and prescribing. And this was actually sustained beyond the first wave.
In the primary care?
Yeah, in the primary care.
So it's all clustered in the hospital care?
So we began to see this real dichotomy in terms of what was going on in terms of prescribing and practices in different areas. And so while everyone was talking about some of the challenges and the actual problems with high rates of prescribing in hospital, which were present, actually there were some areas where perhaps some positive impact had come out of the pandemic. And so it was really, and the thing we're trying to look at now is trying to understand how to maintain those positive impacts whilst minimizing the harmful ones that have occurred during the pandemic.
Yeah. And do you feel that the overprescription in the hospital care, was that appropriate?
I mean, it's tricky.
Or is it difficult to say? I mean, it's probably difficult to get those insights on prescribing behavior.
I mean, in terms of, I think you have to split prescribing in hospitals into sort of people being admitted to the general wards with COVID-19 and those in intensive care, and that there was a difference in the rates of observed infections, and particularly healthcare-associated infections in critically ill patients. But there was overall finding of very low rates of bacterial co-infection in patients coming through the front door in general, and high rates of prescribing. But it comes back to behaviors and how you can actually support decision-making, because this was clinicians under a huge amount of pressure, making decisions with limited evidence base to actually work with. And the hope is that as you begin to build the evidence base and you think about how to put interventions in place to support decision making, you can have a potential positive impact on reducing that amount of prescribing.
Yeah. Well, I think it's clear for our viewers why you got acknowledged for the research you have done, very rightfully so. Can you tell us a little bit about the research focus you're going to have for the upcoming years?
Yeah, absolutely. Well, what my hope is anyway, funding and things providing. But I mean, the big focus is really we have these technological solutions that we think can help improve the precision of antimicrobial prescribing. And it's all very well developing these and validating them in your local environment. But actually what you need to do is evaluate them over a wider range of clinical settings and demonstrate efficacy and their impact on clinical outcome.
That's
so
interesting.
our hope is that as we continue to develop these tools, we'll now be able to start evaluating them in clinical practice, looking to develop clinical trials for evaluation of them for improving the precision of antimicrobial use, but also hopefully through some of these studies where we're focusing on, for example, understanding pharmacokinetic pharmacodynamics in real-world settings, we may also be able to generate data to support other aspects of precision prescribing as well.
Well, it's interesting. Well, let's hope the Young Investigator Award is a stepping stone for more funding so you can make this all come true.
Thank you.
Are there any specific ECCMID program elements that you're very looking forward to, or?
Yeah, I mean, so I think we were talking before the session, just saying how I think even in the last few years we've seen a big or an increased focus on things like artificial intelligence, and even biosensors are creeping through in different presentations now, and so it's really nice to see that kind of merge of technology development with the kind of classical ID and clinical microbiology. But I guess also the other day, one of my colleagues was saying to me, when you come to a conference, what you should do is go and view presentations and things that you wouldn't normally look at when you're in your usual clinical practice or what isn't your area of expertise. And so I think over the next couple of days, I'm really going to try and take that and just get a broad experience for everything there is to offer here at the conference.
Wow, that's excellent. Well, there's enough. The diversity of the program is huge.
Absolutely.
Thank you so much, Timothy, for coming here and telling our viewers a little bit more about your research. That was very valuable. And thank you all for tuning in and for following us today during our ECCMID TV live broadcasts. This was our final broadcast for today, but no worries. We will be back tomorrow morning at 9 a.m. with the highlights personally selected by ECCMID's Program Director, Jacob Morangalad. And also, please note that tomorrow, Monday morning at 9, there is the extra symposium on the viral emergent hepatitis cases that we spoke about this morning also. So tomorrow morning, that is also at 9. And if you want to hear more about the program tomorrow, check out the highlights as well here on ECCMID TV. We have a full day packed for you tomorrow. We will be talking to several keynote lecturers. We will be hearing from the UKIC, what they're working on. We will be showing some selections from the ECCMID Art Gallery, which is also still a tip. Come and to the ESCMID World Village and look at the art that some of our participants at this Congress submitted yourself. There's some really beautiful work there, which may inspire you in your research practices as well. So for today, we're closing off, and we will be back with you at 9 a.m. sharp tomorrow. Thank you for watching, and see you tomorrow.